These are points that I have to address about. AF is the most common supraventricular arrhythmia. It usually is associated with a variety of symptoms of palpitation, shortness of breath, and fatigue. And it also associated with adverse outcome like recurrent hospitalization, heart failure, and most feared complication, that's ischemic stroke. It causes 5 times increased risk of ischemic stroke. And usually it impacts the healthcare and society because the lifetime risk of developing AF is 1 in 5 person and is expected to increase to 1 in 3 person with aging population. We have different types of AFib. First diagnosed paroxysmal AFib when the AFib is less than 7 days. We have persistent AF when it is more than 7 days. And persistent can be divided into early persistent up to 3 months or long-standing persistent more than 12 months. And we have permanent AFib when there is accepted of the symptom by the patient and the doctor. And the first change in the guideline is change from ABC to integrated AF care pathway. This pathway is very important because if you apply this one to any patient, I think we can manage every patient properly. The C is the comorbidities. Usually we have to deal with every comorbidities, and this is an initial step in the management of AFib because without dealing with the comorbidity, the patient will not stay for a long time in sinus rhythm. And usually it helps to maintain sinus rhythm, and treating the comorbidity prevent the progression of the disease. And the guidelines specified these 6 comorbidities, that's hypertension, heart failure, overweight, obstructive sleep apnea, diabetes, and alcohol. The second letter is A, which is anticoagulant. Usually, this is also, there is a change in the score. They usually remove the female sex from the score. Nowadays, the CHA-2DS2-VASc score became CHA-2DS2-VA score. They found that there is no more risk factor for thromboembolism. And every patient we have to calculate CHA-2DS2-VASc score. If it is, if the CHA-2DS2-VASc score is 2, we have it is class 1 indication to start oral anticoagulant, while if it is 1, is class 2A. And please don't give antiplatelet therapy as an alternative to anticoagulant. And why it is important to give oral anticoagulant? If you look to this transesophageal echo, you can appreciate there is a large thrombus loaded in the left atrial appendage, and there is spontaneous contrast. So the patient has high risk for thromboembolism. And AFib is the major risk factor for thromboembolism, irrespective whether it is paroxysmal, persistent, or permanent. And the guidelines support use of direct oral anticoagulant in preference to warfarin because they have less bleeding risk and they are at least non-inferior to warfarin. That's why it is class 1 indication to start oral anticoagulant, direct oral anticoagulant, except in patient with mechanical valve and moderate to severe mitral stenosis. In such a condition, still, there is the indication for anticoagulant is warfarin. And the second letter is R, reduce symptom by rate and rhythm control. This is a very important portion of the management of AFib. I want to share with you this patient. This is 45 years old, history of persistent AFib, hypertension, diabetes, usually visited us in 2022. At that time, ejection fraction was 50 and asymptomatic and kept only on beta blocker. At 2023, ejection fraction slightly decreased, but still asymptomatic. In 2024, the patient developed shortness of breath and diagnosed as dilated cardiomyopathy and received diuretic, beta blocker, apixaban, and digoxin. And we gave him high-dose amiodarone, preparation for DC shock. This is the ECG of the patient, you can appreciate there is no P wave and there is irregular interval. So AFib is the most common persistent arrhythmia and frequently associated with tachycardia-induced cardiomyopathy. Usually, LV dysfunction is found in 20 to 30% of all patients with AFib, and 10 to 50% of patients with heart failure also develop AFib. So the common question we always asking about whether rate or rhythm control is better in patients with AFib. We have multiple trials. Start with the AFIRM trial, which is published in 2002 from New England Journal of Medicine. This trial randomized patients into two groups, one with rhythm control using antiarrhythmic drug. The second group was rate control medication. And actually, the composite endpoint is death, disabling stroke, major bleeding, and cardiac arrest. The results of this trial was disappointing in terms of rhythm control regarding reduction in major adverse outcome. However, there is some limitation in this trial using only drugs for rhythm control without ablation, and you know the drug is neither effective nor safe. And at 2019 also, there is another trial, which is Cabana trial, using the catheter ablation against medication, including both rhythm and rate control. Again, the primary endpoint is death, disabling stroke, and bleeding. The results of this trial is disappointing in terms of any survival benefit. However, there is significant improvement in the quality of life. Now let us see in patients with recent AF. We have another trial, which is also published in 2020, which is East AF Net 4 trial. They randomized patients with new onset AF, less than 1 year with comorbidities. And the primary outcome was cardiovascular death, stroke, and hospitalization. Actually, the results of this trial was promising in improvement of the survival of patients with new onset AFib and decreased hospitalization and heart failure. Let us see in another group of patients, that is heart failure patient. Again, we have a CASTLE-IF trial. They randomized patients with heart failure into catheter ablation and into medication. The primary endpoint also all-cause mortality and worsening of heart failure hospitalization. Again, in conclusion, the catheter ablation for heart failure associated with significant reduction in the composite endpoint of death and hospitalization. So that's why catheter ablation became class 1 indication for patients with heart failure and decreased ejection fraction, especially in patients with cardiomyopathy, tachycardia-induced cardiomyopathy. In conclusion, the rhythm control for general population offers only symptom control, only quality of life, but without survival benefit. However, in certain group of patients like heart failure and recent onset AFib, there is significant reduction in the mortality and also improvement in the quality of life. So coming back to our patient, after we gave DC cardioversion, this is echocardiography just 3 months after DC, and you can see here after patients still remain in sinus rhythm, the geometry of the heart is changed, the size and the function is improving. Rate control in clinical practice. We have certain condition, usually we prefer only rate control. For example, if the patient is old age, more than 65 years, and less symptomatic, if the patient has recurrent AFib, especially after catheter ablation, or the patient has previous antiarrhythmic drug failure, or the LA is hugely dilated, we expect that there is no more chance for rhythm control. And regarding strategy, usually the linear rate control is accepted. I mean, the heart rate less than 110 is accepted in most of the patient. However, if the patient has persistent symptom or deterioration of the LV function, or if the patient has CRT, that the AF interfere with the function of the CRT, at that time, more strict rate control is necessary, less than 80 beat per minute. And regarding the choice of medication, it depends on the patient's profile and depends on the ejection fraction and comorbidities. If the ejection fraction less than 40, you can use only beta blocker or digoxin either alone or in combination. If it is more than 40, you can use all rate-limiting medications. And rhythm control in clinical practice. Usually we prefer rhythm control if there is first episode of AFib, if the symptomatic patient, despite rate control, or the heart failure, we suspected tachycardia-induced cardiomyopathy, or young AF patient to prevent electrical and anatomic remodeling. And of course, we have antiarrhythmic drug or catheter ablation for rhythm control. And again, the choice of the medication, it depends on the ejection fraction or patient profile. Usually, if the ejection fraction less than 40, the safest drug is amiodarone. However, if there is no structural heart disease, you can use flecainide, propafenone, dronidarone, and catheter ablation nowadays upgraded, become class 1 indication for patients with paroxysmal AF, even before starting antiarrhythmic. That's why the catheter ablation upgraded from class 2A to class 1 in the recent guideline. For persistent AF, again, the choice of the medication is similar. If the patient not respond to antiarrhythmic drug, the catheter ablation, again, is class 1 indication. However, before initiation of antiarrhythmic, the catheter ablation is class 2B. And you know the trigger for atrial fibrillation is arising from the pulmonary vein. Usually, if you isolate the pulmonary vein, this trigger cannot cross to the LA. And we have many modes for ablation. We have radio frequency ablation. You can see here point-to-point ablation. When we isolate the pulmonary vein, there is no signals more. And now with the development of new technology for AFib, the AFib ablation become more simple with less complication. And even we can complete it even less than half an hour. This is a cryoballoon ablation. Usually the balloon is occluding the pulmonary vein. With single shot, you can isolate all the pulmonary veins. And now this is a pulsed field ablation. Also with pulsed field, with single shot, you can isolate pulmonary vein. And the last letter is the E, evaluation of the patient. Of course, every patient with AF needs serial evaluation for presence of any new comorbidities, any change in the symptom. So take-home message, the guideline recommend treatment using AF care pathway, and comorbidities should always be managed in addition to the management of AFib. And also every patient should calculate Chad's VAS score. And in general population, the rhythm control strategy offers only symptom control in comparison to the rate control strategy with no survival benefit. However, in recent onset AFib less than 1 year and AF in heart failure patient, rhythm control and catheter ablation decrease MACE and improve quality of life. Thank you.